Yeah. I mean, these I think are really, really hard. I think there's some movement to kind of think about them as low-grade adenosquamous tumors. Are you part of that discussion at all?
Yeah, well, it's coming from France.
Yeah.
Where they have looked at the follow-up of, I think, 12 cases, and none of them metastasized. Then we also, we also had a discussion about the case where we received it from outside. The pathologist didn't want to call it carcinoma, even though it looked just like this, but didn't want the patient to be treated with radiotherapy, chemotherapy, or at least being classified as a carcinoma. So we decided to do a project and looked, and none of the cases that we have diagnosed has ever metastasized. There is one case that recurred, but basically these tumors,
very indolent.
It's like MGA, microglandular adenosis. Maybe it's an invasive carcinoma, but it's called microglandular adenosis.
Yeah.
And that the name kind of dictates how we think of it. These have been called carcinomas by Dr. Rosen. Now we need a lot of evidence to prove that they're not carcinoma and don't metastasize. But there is this movement now.
Maybe by the time the next WHO Blue Book is out, it will be low-grade adenosquamous tumor. But I had another case similar to this as well. And again, I sort of really struggled. I think it's almost more, it's almost easier on the core biopsy where you don't have the sort of influence of biopsy site change to kind of make you concerned about this just being a reactive change or sort of squamoid change due to the biopsy site. But anyway, so that was a struggle in that case. All right, I might have, let's see. This one, I think, a little easier because you can see that there's this kind of central area, but what I rely on is these adenosquamous looking glands and nests kind of creeping out beyond what would be the center of a complex sclerosing lesion. So once they start to kind of percolate out beyond the TDLUs, the terminal duct lobular units, that's where I start to get concerned about it and worry about it being a low-grade adenosquamous carcinoma. And then once you start seeing them, then you start seeing them everywhere, I think, between the ducts and lobules. But I think this is a really difficult diagnosis. Sorry. Trying to see show you the little nests and hordes of cells that percolate out between the glands. There's the biopsy site. Fortunately, these things aren't that common, but so that's another example of a similar type of case.
Sorry, could you comment about ringadenomatous tumor and the differential with
syringomatous tumor?
Yes. Okay.
Yeah, so I think more if it's deeper in the breast, although, maybe that's not necessarily the case, but if it's deeper in the breast, I would go with low-grade adenosquamous tumor, low-grade adenosquamous carcinoma, as we have to say right now. But yeah, that would be in the differential diagnosis more superficially. Well, yeah, that's a whole conversation. Doesn't have a good answer for that. All right, so this is a young woman with a breast mass that is hot and painful. So she has erythema of the overlying skin, and so this was the core biopsy from that area. And I'd be interested to hear if people see a lot of this. All right, so anybody, any of our young people young trainees want to have a go at describing this?
Who want to describe the case?
No? Can you see it? Is it in front of your head?
So
What
are
do
they epithelial, the cells? Do you think they're epithelial? Or not? There are a lot of eosinophils.
What is the main cell type that you're seeing here? Inflammatory cells, yeah. So lots of inflammatory cells. Neutrophils, right? Lots of neutrophils around and about. I think we passed some areas that were more histiocytes, right? And then another feature of this particular process is these little holes, spaces, with kind of a cuff of neutrophils around them. That's quite characteristic to see these spaces with cuffs of neutrophils around. There are some eosinophils in here as well. Anybody have any thoughts on this? There's a giant cell, so you've got some multinucleated giant cells and histiocytes as well. Sometimes you can see, maybe you could say there was a bunch of histiocytes there, maybe a little bit granulomatous, not exactly, not the best granulomatous process, I would say. Let's look at one of the other cores. Anybody seen this before? Know what this is?
Is there something perivascular also?
There is a little bit of blood there. Not an angiosarcoma though. At least I didn't call it that. No, but that's a good thought too. So
is there any data about
so she had recently been breastfeeding. So okay, well, so maybe this is maybe you don't see this very often here, or maybe it's not biopsied as much. We seem to see a reasonable amount. I don't imagine Eddie sees that much. I don't know, maybe you do. Yeah. They think it's carcinoma, yeah. No, so what this is an example of, and it's a fairly good example of the entity. Sometimes it's more granulomatous looking. Sometimes it has more of this acute inflammatory kind of phase. But this is an example of something called cystic neutrophilic granulomatous mastitis. Long name. But cystic because of these little spaces. They're not really truly cysts, but they're these little spaces in which bacteria reside. So I'll show you the stains in a second. So you would do gram stain on this and bug stains. So cystic neutrophilic granulomatous mastitis, you have granulomatous inflammation, often sort of lobulocentric granulomas, as well as the neutrophilic process. And as I said, the neutrophils tend to kind of cuff. One of the things I see often is helpful is the cuffing of the neutrophils around these cystic spaces. Let me just see if I've got another case to show you that is. Another example. Here's another example. And so this is usually in kind of younger women who either have just, finished lactating, still lactating, recently pregnant. So this one is another one, and you can see it's a little bit more granulomatous here, right? You can see granulomatous inflammation with lymphocytes around the granulomas, and then giant cells as well. Here, more granulomatous. Again, this sort of area with the cystic spaces, which has this little cup of neutrophils around. So this one is a really glorious example of cystic neutrophilic granulomatous mastitis. And see all the granulomas there? And then what they are associated with, most commonly associated with Corynebacteria. Yeah, Corynebacteria croppenstedii, which is a bacterium that is quite fastidious. It requires special culture media. So you don't always, you know, if you're sending a sample to the microbiology lab, they basically have to be alerted to the presence of these bacteria because, as I say, it requires special culture media. And often the patient, because it's a younger patient, it's sometimes a hot mass, maybe the patient is febrile. Often they've received antibiotics, not necessarily antibiotics targeting this particular bacteria, but sometimes we don't see the bacteria, I think, you know, because they've received several courses of antibiotics or even steroids before we see them. But sometimes, you know, it's worth doing the bug stains, and you may see these little gram-positive rods here. Yeah. Corynebacteria. Corynebacteria. Yeah, so sometimes you can see them in the, you should look in those little cystic spaces to see if you can see the bacteria. Sometimes you'll see them on, even on H&E slides. Let's see if I can find it. Obviously, it's really hard to be confident on H&E, but oops. I don't know. I don't know whether I'm seeing them for real there or that's just junk in there, but you should look on the slide to see if you, oh, I was trying to get rid of the arrow. But, so you should look and see in these spaces to see if you can see the bacteria, and obviously always do the stain. Our radiologists are pretty adept at considering this diagnosis, so they will send a sample to microbiology in patients where they're thinking about it, or it might be the nurse practitioner that's thinking about it and puts on the requisition to rule out, you know, CNGM, we call it CNGM, cystic neutrophilic granulomatous mastitis. And so the micro lab knows to do that. So when we're signing these cases out, we always look for the micro report to see if they've seen any bacteria. They may even have the result by the time we get our gram stains back, for example. And so, you know, we see this fairly frequently, actually. So it may just be that your practice is not biopsying these cases.
Of Hispanic origin, South America, Mexico, those are the areas in the United States, also Texas, also in New York.
Yeah.
And then I had 2 cases in 1 week, a record. Then I haven't seen any.
Yeah.
But the infectious disease person called me and said that they give methotrexate.
Oh, really?
Yeah, and that helps to, you know, stop the inflammation,
Yeah.
and the patients do well.
Yeah.
That's what she said. Yeah.
Because it's really,
Something to reduce the immune response.
Yeah,
So that's something.
yeah,
I had the feeling of a Wegener
yeah.
at the first
I mean,
glance. So
yeah, these other thoughts, Wegener's, Rosai Dorfman, those kinds of things are good thoughts. But this actually is way more common than the other things that were mentioned or considered. And it's quite, you know, it's quite difficult to treat. I think the patients really, it can keep coming back, so it can be quite difficult. All right, this one, not necessarily so uncommon, but just a nice example of so bright. Okay, so we're up in the nipple section here. And I'm showing you this one more to show you the next slide. But so obviously now we have some exudate, and some exudate, some atypical cells within the Paget's, did somebody say? Yeah, Paget's disease, definitely what we need to be thinking about here. We've got these really atypical epithelial looking cells. Hang on a second. They look like a different population of cells. They look very similar to breast cancer cells, running along the sort of basal layer, but also percolating up to the surface. And then you can, as you know, the vast majority of patients with Paget's disease have an underlying breast carcinoma. This patient was no exception. See DCIS and invasive carcinoma down here in the ducts below the nipple. So, and usually these tumors are HER2 positive, which can be a helpful confirmatory test. If you have a biopsy of the nipple and you're not sure, that can be something that can be helpful. They can be mucin positive as well. Sometimes we are positive, but not always. So that's just a nice example of Paget's disease. And then to go along with that, or to contrast this case, which also came in with a diagnosis of Paget's disease. Okay, so this one came in with a diagnosis of Paget's disease. You can see why that would be the case. So what do people, I mean, I'm sort of leading you to the fact that this is a fast that she came in with diagnosis of Paget's. What do people have any thoughts? How does it look in comparison?
I'm thinking in the differential diagnosis of a squamous cell carcinoma or a melanoma too. In this case, maybe, yeah, the cells are atypical and large too, but sometimes they doesn't look seem like the previous case, like.
Yeah, I mean, it's funny. I don't. So this one was definitely funny, and I can't. What made you think about squamous cell carcinoma and melanoma? Is it just that it's always in the differential diagnosis, or was there something that made you say squamous cell carcinoma? Yeah, I think that's exactly right. I mean, I don't think there are really well-described criteria for how to separate these things out, but I think that was what was my kind of, I don't know, reservation or hesitation as well. It's that they're all together, all the tumor cells that we see are in a big patch or big sheet. Whereas, as exactly as you said, for Paget's disease, you see these sort of scattered cells. Sometimes they're in small nests, for sure. But here it was sort of broad areas of these tumor cells. And I think it had probably come in with a HER2 stain that was HER2 negative, but they still called it Paget's. And so we ended up doing a P63 stain, and all these cells were P63 positive. So we did call it squamous cell carcinoma in situ. But yeah, so those two differentials that you mentioned are strong differentials for a diagnosis for the diagnosis of Paget's disease. You always have to think about squamous cell carcinoma in situ and melanoma. And I think which immunostains you would use to make that discrimination. I think HER2 is very helpful, although Paget's could be HER2 negative. But really most of them are HER2 positive, P63 in this case, or you could do melanA or HMB45 in a melanoma case. But yeah, so this was interesting. I haven't seen another example of this in the nipple areola area, but definite pitfall for that differential diagnosis. Questions or comments? All right, so okay, so we saw some examples of this yesterday, but you never see too many, I guess, right? So here we are up near the nipple again, or the skin surface of a breast mass. Okay, so what are people's first impressions about lots of blood? What did we learn yesterday? Angiosarcoma, yeah. Yeah, so we're up in the skin surface. I didn't give you any history, but presumably this patient has a history of breast cancer treated with radiation therapy. Always have to think about angiosarcoma in that setting. This one is, much easier, I think, because it's really quite high grade. But, you can imagine if you have a core needle biopsy of something like this, or a punch biopsy of something like this, there would be many different entities in the differential diagnosis. But I think strong consideration should always be given to angiosarcoma. And just remember that angiosarcoma, as was discussed yesterday, can have lots of different appearances, can be very well differentiated and subtle and super difficult to see even in the skin. Because the endothelial cells can be really kind of, serpiginous and kind of creep through the dermal collagen. So that can be really difficult sometimes. And it can be, so you can miss it for that reason. It can look quite well differentiated and have well-formed vessels. So you can miss it for that reason. I would say that the sort of clue sometimes with the well-differentiated version in the radiation setting is that the endothelial cells seem to be sort of too high grade for how well differentiated architecturally the vessels work. And then the epithelioid variant is also a pitfall, as we both shared yesterday. So this is just a nice example of an angiosarcoma occurring in the superficial breast. And then to contrast with that, okay, to contrast with that, I have this case. And hang on a second. I'm going to find the area of trickery. Okay. All right, so this is a large breast mass in an older patient. So what are people's sort of initial impressions here? What kind of lesions are you thinking about just on low power? It's a large breast mass. Older patient in the breast. This is deeper in the breast. I know I'm only showing you one area. I can go on higher power. You move around a bit. Well, I don't know about you, but I would think about angiosarcoma here as well, because it looks quite like it's interanestonosing vessels. There's the sort of collagen stuff. We know that angiosarcoma can look like lots of different things. I would say that the cells lining these vascular-like spaces, they look plump and atypical to me. So, I'd definitely be thinking about angiosarcoma. Would anybody be thinking about something else? Say again? Very little blood. Actually, that's a really good point. And we learned that yesterday, yeah? Sylvie, do you have something? Osseous differentiation. Oh, that's a good thought. Yeah. Yeah, right. Wow. Well, somebody should be hiring her. This is a metaplastic carcinoma. So that's a really good pickup there. Obviously I showed you the area that had the kind of pseudovascular pattern. There's kind of a little bit of trickery, and you would look around much more, and we see areas that have these spindle cells that, anytime we have a spindle cell lesion in the breast, we're going to do keratins and P63. So even though you might be going down the angiosarcoma path, first of all, you would do your keratins because of all this spindle cell differentiation. And actually, as I recall, I think this patient had a history. She had like a diagnosis of invasive ductal carcinoma on core biopsy. I think she had an excision, and then she very shortly after had another, it seemed like there was a residual mass or something. I don't remember exactly the story, but there was another core biopsy done, and actually it was called metaplastic carcinoma on the core biopsy, based on workup. And, I still on the excision thought, gosh, this surely is angiosarcoma, because it really, so much of it had that look about it. But anyway, yeah, further workup, of course, showed that it was, look at all this. It really looks sort of so pseudovascular. And then I think the biggest clue, of course, was, let me see if I can find it. So there's DCIS. Now, I guess that's not definitive proof that this is, metaplastic carcinoma, but having an in situ component is helpful in terms of thinking about something being a carcinoma in the breast. And as I say, this was strongly positive for multiple keratins and for P63, and it really highlighted all these epithelial cells in this sort of pseudovascular area. So I thought that was a really interesting pattern. All right. Okay, this is another young patient. And this is a deeper level. I don't have the original slide, so it's kind of cut through now. But this is another young patient. She may have been 28, 32, something like that. And they say we don't have much left on this, so it doesn't look quite the same, I feel, in my memory as what it does now. But I'll show you. So there's this little piece of tissue. It crushed. So I don't know, what do people think? Benign, malignant, epithelial, non-epithelial? Non-epithelial? Benign, malignant?
Malignant, lymphoma.
Yeah. Oh, so good. Well, so I had this case. I feel like on the earlier levels that it looked a little more epithelioid. So I had this case, and I called it a poorly differentiated poorly differentiated tumor. I had only given a preliminary diagnosis and called the clinician, said it was poorly differentiated tumor. I was going to do epithelial markers and work it up. And I actually had ordered the ERPR in HER2 as well. And in the interim, and before the markers came out, the patient went to a different institution. So I hadn't finalized it. She went across the street for a second opinion, and they started working up on the premise of, she had cancer. breast cancer. And I hadn't finalized it like that, but the communication happened such that it was cancer. But it was a lymphoma. It turned out to be keratin negative. Further workup, it was a diffuse large B-cell lymphoma. But yeah, so I think just goes to show that, you know, these things can be, if you're trying to rush through cases, you can be caught out thinking that something's a poorly differentiated carcinoma when, you know, when it's not. And I mean, I'm thankful that I didn't sign it out as that, you know, that I knew to like do the workup further. But, you know, the communication happened anyway. And so then there was some backpedaling that needed to be discussed to make sure that the oncologists understood what the work in progress was. So, but yeah, this one was a lymphoma. All right. All right, this one's a really slightly feeble one to give you, because you're also very good. So this is actually a chest wall mass. Yeah, she'd already had a mastectomy, I think. Let me see. I didn't see any breast tissue. Yeah. So, benign or malignant? Malignant, right? Epithelial, non-epithelial. Recurrent carcinoma, metastatic carcinoma. Seems like a ovarian. Yeah, I think that's a good thought. It has some of that look about it. I think this one's really hard. I think it actually looks like it could be a primary breast. I guess some of the larger vacuoles maybe seem a little atypical for breast, but many areas, I don't know, I think it looks kind of like. This is actually a patient with a history of lung cancer that had metastasized to multiple sites, and this was one of her lung cancer metastases. Really tricky. And yeah, there was a core biopsy of it that came first. And again, it was one of those situations where you're thankful that you have the history of a patient with lung cancer, because if you didn't, I think it would be really hard to not go down the tubes. I don't know. Yeah, I think so. I don't know. I would have a real difficulty with this one. Okay, I'll show you one more. All right, so this one. So Dr. Brogi taught us earlier that we always have to look and see if there's breast tissue. Not sure, but this is a breast mass. Have it. What are people's thoughts on this one? Melanoma. Wow, you guys are so good. Yeah, it is a melanoma. Why do you think it's a melanoma? Yeah. Yeah. Yeah, so that's right. It, you know, it's It's all those things. So large cells, abundant sort of amphiphilic cytoplasm, pleomorphic nuclei, and you know, there are occasional mitotic figures around and about. No pigment. You would look for pigment to help you as well. This case didn't have any pigment that we could see. But yes, this is a case of melanoma metastatic to the breast, or at least the chest. And you know, I think these are things where you just have to sort of be slightly on your toes and think about it. If you did call it cancer, triple negative, you should think about it, right? So those are times where you need to kind of catch yourself, because some of this, you know, intracytoplasmic vacuoles, you might think it's, oh, an alveolar variant of lobular or something, but if it were ER negative, that would be slightly weird. So that's something that you need to think about. And then I have another example of oh yeah, here's another example. This one did have a lot of pigment in it, so that was you know, helpful to come to the correct diagnosis. It looks cytologically, I think, fairly similar. You know, similar types of cells with that kind of abundant cytoplasm. Sorry, let me go to the area that's slightly better. Similar types of cells, I think, given changes in staining quality, and but lots of pigment, which doesn't look very there. So that was another example of metastatic melanoma in the breast. Okay, and then I have one other that I wanted to. Oh, actually, I know everybody's probably getting hungry. Okay, so this was, how about this? This was a core needle biopsy done in a patient with, I think she actually had calcifications on screening mammogram. Yeah, calcifications on screening mammogram. What do people think about this? So calcifications. Get levels. I think you have the pathology here, but you could get levels. What would you be looking for? Tumor cells, right? Yeah, there are giant cells. So what does that make you think about? Some material, some foreign material. Yeah, I think you're all thinking along the right tracks. That's great. So definitely, you know, it looks sort of mucinous-like or mucin-like. So you have to think about mucinous carcinoma. The trainee I was working with wondered about mucocele-like lesion. The thing that's a bit funny for mucocele-like lesion, I would say, or even for mucocele-like lesion, it's sort of scattered. This material is kind of scattered. Speaking to the giant cells, here are a lot more giant cells just here. So the giant cells kind of make, I think one has to be careful not to misinterpret them as epithelial cells, which may have been the route that this sort of new trainee was going. But these look like they're engulfing this material here, right? So it makes you think about it being a foreign material once you get to look around a little bit more and see those different things. But so I think mucocele-like lesion, mucinous carcinoma, foreign material. So if we're thinking foreign material, what clinical scenarios do you have to think about? Yeah. Yeah, so that's right. So some cosmetic procedures, or maybe sort of backstreet cosmetic procedures, had direct injection of polyacrylamide gel into the breast, and this can lead to some years later, sometimes it can swell or calcify and can have pretty unpleasant kind of consequences. I've just seen a couple of these recently. I haven't seen them before, so I don't know if it's a new practice or we're some years down from a new practice that now we're seeing this, but I don't know whether anybody else has seen this at all. You've seen one, but yeah, so the clues, I think, are the sort of scattered nature of that mucinous or foreign material, the giant cells, you know, absence of epithelial cells that kind of cued me into it. So, all right, should we stop there? We should stop.